Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. One issue that comes up over and over and over again from the viewers is they want to talk about what I would call minimally invasive surgical techniques and robotic surgery. And the reason they want to talk about it is because they know in their minds it causes less pain and less cutting. So we have experts here. Experts. We have him sitting in front of me, Dr. Ariel Rodriguez. And Dr. Rodriguez is a medical doctor, a surgeon. And we're going to let him tell us what his field is. And also we got Alia Abdulla, who I'm proud to say is a graduate of Nova Southeastern University. And she too is, I believe, an oncologic surgeon, if I'm not mistaken. And we're going to talk about robotic services, and therefore we're going to talk about minimally invasive surgery. Dr. Rodriguez, tell us your field on specialty.
Good morning, thank you for having us here. I'm a bariatric surgeon and training minimally invasive surgery. We do all the weight loss surgeries and plus all the general surgical techniques that we do in the regular hospital, and then we apply all these minimally invasive techniques, including robotic surgery. The two most commonly performed procedures still the gastric sleeve and the gastric bypass surgery for weight loss.
Alia Abdulla, you perform some very significant surgical, shall we say, procedures, and you do it through robotic techniques with minimally invasive, I guess, implications. So let's talk about what you do.
Thank you for having me on the show, first of all. But yes, I am a surgical oncologist, and I perform a lot of cancer surgeries utilizing minimally invasive techniques. So specifically, I work on the GI tract. I do colon surgeries, gastric surgeries, and rectal surgeries using the robotic systems. And yes, the patients tend to do much better. They end up being able to go home faster. They end up having less pain. It's an amazing technique that the patients really do benefit from.
In your case, for example, in GI and I would say that the whole systems related to oncologic work, you are not going in to prevent something, usually. You're going in to present to the patient an opportunity to a cure or a patient therapy which enables them to live longer lives, correct?
Yes.
So let's talk about that.
So I do specifically treat a wide variety of cancers. Specifically, the cancers that I treat with the robotic system or minimally invasive techniques are mainly the GI cancers. And when a patient comes to me, yes, it's usually to remove their cancer to allow them to have a longer lifespan. It does specifically tend to give them a better prognosis and a prolonged lifespan. Specifically, minimally invasive surgery has evolved. It began first in the 1980s as laparoscopic surgery, keyhole surgery, some people refer to it as, or laser surgery. But it just means surgery that is through small incisions on the abdomen. Through time, though, I would say that laparoscopic, minimally invasive surgery has evolved. And now we're using this amazing technique using a robotic system that really does make an even bigger difference in the patient's outcome. And yes, they do have a difference in lifespan when I am able to offer them a surgery.
You know, a question that comes from the viewers, and both of you can relate to this, is that when people think of surgeons, they think of hand coordination and technique, you know, cutting.
Correct.
And yet, it's really the same coordination and technique using robotic controls, correct?
Yes, I personally tell all my patients that the robot does not perform the surgery, that it really takes an experienced operator and it is just a tool that I use in the operating room. Like many of the tools that have developed in the last century, this is just a newer tool that the surgeon, myself, can use to enable the surgery to go in a way much more precisely and much more defined. And so yes, a lot of hand coordination, a lot of the same skills that surgeons have always needed, you still utilize those skills.
Right. And Dr. Rodriguez, as I hear from colleagues of yours and yours, is that the robotic techniques enables individuals to get a better view
Correct.
of the problem that you're trying to solve. Is that
Correct.
true?
I mean, the magnification, almost 3D visualization of the tissues, the handling of the tissues, the freedom of movement that the robotic system allows you is way beyond that we can do with straight instruments in minimally invasive surgery. So the pictures are almost perfect, it's like you were right there. And again, how we can handle those tissues are just improve the abilities that you have and the skills that you have, but you still need that hand-eye coordination like Dr. Abdulla was saying.
Let me stay with you for a minute because bariatric surgical specialty, surgical techniques are very, very interesting because as people know, we have well, it's not an epidemic, I think it's an endemic. We have an obesity problem in this country at this time.
Correct. I mean, the obesity epidemic almost is reaching out of proportion. I mean, the resources that we need to invest in them is just draining the healthcare system. It's becoming the #1 preventable cause of death, just at almost the same level as smoking. And the problem with obesity is what comes with it, which includes the diabetes, the hypertension, the heart problems. And one of the issues is that once obesity has set in, it's very difficult to resolve without one of these interventions that we offer. We have tried diet and exercise for a long time, and the results are not great. So a certain proportion of the population that are obese, surgery may be the best option to control those comorbidities that may end up in the future causing a lot of harm. And the techniques have evolved to the point that the chances of something going wrong with these surgeries are very, very low, and the results are over 80% success rate, which for any long-term disease over there is pretty remarkable, actually.
You know, let's stay on this bariatric surgical issue for a second. Isn't it true that you will not do a surgical technique unless someone has a certain body mass index
Correct.
of a certain number? You want to talk about that?
Yeah, absolutely. We go by NIH recommendations, which still states that persons with a BMI of over 35 with either hypertension, diabetes, or other obesity-related diseases will qualify for the surgery. Or if you're severely obese, which is a BMI of over 40, then we think that surgery is still the best option out there. And looking better is just a side effect of the surgery, when in reality what we're looking for is the health issues, resolving the health problems that the patient have right now or may develop it in the future. And that's why, like anything else in our professions, early intervention works better than trying to treat diseases. So prevention is very difficult, and like I said, once obesity has set in, we find that patients have tried everything: medications, diets, pills, injections, etc., with no good results. And even though health, lifestyle modification is still part of the program and absolutely necessary in order to be successful after surgery, we don't think that those alone will work or provide the same results as surgery does.
Let me stick with you for a minute. A lot of your colleagues that are involved in bariatric surgical techniques actually state to me, and they've stated in this program elements, the fact that they always refer their patients on to some nutritional counseling and also to psychological counseling.
Absolutely. Obesity is a multifactorial problem, and treating just how much you can eat will not solve the problem. We absolutely take every patient through a multidisciplinary comprehensive program, which includes nutrition evaluation, psychological evaluation, and wellness preparation for surgery. And what we find that the patients that go through surgery, the aspect that they struggle the most is the emotional and psychological aspect, because they cannot eat as much as they did before, and they have that problematic relationship with food. Still have to make healthy options, still have to control what you eat, but controlling what your brain is telling you versus what your stomach is telling you is very, very difficult. And we see that in our support groups all the time, where patients just keep telling us, we still struggle afterwards, because that's pretty much a lifelong struggle after surgery. But with the help and the support of the program, we can take patients through it. And even though it's going to be difficult, still it's about what you're going to achieve afterwards, which is a healthier weight and a healthy lifestyle altogether. Just doing the surgery itself will not fix the problem. There are other factors that are included in the treatment process that are absolutely necessary to be successful. There are changes that are going to be necessary, there are compromises that are going to be necessary, and all of those are difficult. And we just have the program and the support necessary to take the patients through that. And the more willing you are to follow our recommendations, we think that the better chances of success, for sure.
The issue of what you do is there's so many multiples of variations of problems, everything from swallowing, esophageal issues, all the way down to the whole GI tract, stomach issues. Let's talk a bit about that.
So basically, I would like to mention that in terms of the role of the psyche in relation to cancer, I think that having a lot of psychological counseling in cancer is also important, and it actually influences how well they do. And so when you are specifically referring to having trouble swallowing or having nausea or having problems after surgery, some component of it can be psychological as well. And so becoming comfortable with their diagnosis, I think, is important. And so part of my role as their physician, I really do take that into consideration, and I try to make them comfortable. And I think that actually helps them with the actual process and the actual surgery at times. But specifically, different surgeries, they have different influences on the symptoms that they may feel. I also do pancreatic surgery, and there's usually a lot of GI issues related to pancreatic surgery. But I always tell my patients that it is, at times, it is expected, and I will help them get through it and help them deal with the issues. And so after any type of surgery, I always try to work through their new issues that they may have.
Let's talk a bit about, your area of involvement is so complex, but there's the application of new, I don't want to say pharmaceuticals, they are new elements of what I would call the new way to deal with the treatment, aftercare treatment. So you want to talk a bit about it, like the gene expression issue, the gene therapy, things of that nature?
So there's new data and new studies coming out related to cancer every day. And so the most recent progressions and the most recent data has actually been something called liquid biopsies, where it's basically specifically looking at gene therapy and basically looking at a patient's genetics. Now, I wouldn't say that it's applicable to everyone, and so that's why it's important to go to a cancer physician when you have a diagnosis of cancer, and they will guide you as to whether or not it's indicated in your case. And different cancers have different types of liquid biopsy. That's actually the formal term for it. Different gene testing, and so it's always important to go to a cancer physician so that they can tell you which one is applicable to you. I think that their psychological status is very important. And so one of the things is when patients come to my office and say, for example, they come alone, I always encourage them at their next visit to bring their family or whoever their support system is. Because I think that cancer especially, but not only cancer, I think any surgical procedure, you do need some support. And dealing with the acceptance of your problem really, to me, helps you get better. And it helps you do better in terms of your recovery as well. And so I always encourage my patients to involve their family and or their support groups or support whoever their support person is, and it usually does help them.
Let me just stay with you for another minute relative to these immunobiologic treatments which the oncologists will apply based maybe after a surgical technique, or they find out. I mean, I know there's been some dramatic things you say, both of you. Everything changes. I mean, it's no longer, this is what I know, this is what I was taught in school, and this is where I'm at. No. It changes. It's changing so fast. To me, it's wonderful. I think it's terrific. But the individuals that you care for, you see their, either the gene alignment in their life, and or the fact that they haven't seen a doctor for 3 years or 5 years. And I'm going to ask you an oversimplistic question, because you see a lot of rectal cancers, you see a lot of GI tract cancers and otherwise, and yet there are always points in time when these patients should have seen their doctor. So all I'm asking you is, when do you believe that John Q. Citizen who's watching today, who maybe doesn't even have any of these symptoms, how often should they have a checkup? For example, how often should someone have a colonoscopy or an endoscopy? I mean, something. I mean, tell me.
So personally, I really do believe in preventative medicine. I think that our country, United States, needs to actually focus more on preventative medicine. And so in terms of preventative medicine, that can vary from country to country depending on exposures. So for example, in South Korea, having an endoscopy or an EGD, they actually are sometimes indicated to have that every year. And that's because of their exposures to nitrates in their foods. However, in the United States, we don't have as much of an exposure. And so it does depend on your environment as to what types of preventative medicine or preventative indications there are. But for example, colonoscopies, it is important to have a colonoscopy at the age of 50. And depending on the findings, then you would either have an indication for a colonoscopy either yearly or every 5 years, depending on the findings. If you do have a family history of cancer, though, then you want to have a colonoscopy 10 years before the age that your family presented with the cancer. But in general, preventative medicine, I think, is really very important. And so it is important to see your primary care doctor. I think that your primary care doctor can help you identify the issues that may be coming, that may be approaching your health. And I think that every patient should at least try to see their primary care physician, at least, I would say, quarterly, or twice a year.
Yep. So, Dr. Rodriguez, what do you have to say? I mean, you usually see the patient at the point in time when they meet all of the NIH standards and whatever, but you're in constant contact with all these primary care physicians and with patients, and I'm sure that in your correlation of getting information from these people, you have to give them some content matter and say, listen, I've done this, but I want you to see a physician X times a year. What do you say?
Well, like you two were discussing, this is an area that keeps changing, and definitely right now we see that patients are more involved in their own care, and they're looking this information. They're discussing more complex issues with their primary cares, and they're taking over their health, and we encourage that. I mean, they have to be an advocate of their own health, and we see that it all depends. If it's a healthy person with not a significant medical history and not significant exposure to diseases or risk factors, then that follow-up may not be the same as somebody that has a genetic predisposition to some of the diseases that we're talking about, and somebody that is constantly exposed to some of these adverse agents, and the follow-up is going to be completely different. And what we think is that in the future, hopefully not too far from now, we can just do one test and realize who's gonna need what at what time, and predict things and start preventing some of these diseases from developing. Like Dr. Abdulla was saying, hopefully we can in the future do a genetic test and see what risk factors you're exposed to, and decide, well, if you keep along this path, these are the diseases that are going to develop. However, if you take a different path or avoid certain carcinogens or certain types of food, maybe we can avoid obesity, maybe we can avoid cancer, maybe we can avoid heart disease. But until we have that, we still need to do what we're doing now, which is regular checkups, at least like you two were discussing, once a year or twice a year. And depending on that discussion with your primary doctor, then you should put the schedule for the next appointment and see what are the things that you can improve in your life now, so in the future none of these diseases would affect you.
Well, I'm glad you hit it right on target, because I always tell the folks at the end of the show, I say, take good care of yourself.
Absolutely.
And taking good care of yourself is really it's hard to say to someone what you should do, but coming from professionals like yourself, and they're listening, believe me, they're listening, it makes me feel good that both of you have said basically the same thing, because I know that Dr. Abdulla came up in medical school with the idea that prevention and wellness is a primary focus of any doctor's practice. I know that. And I'm sure that in a way, you listening to where you got your residencies and training, I know that that's not dissimilar. So I really believe that the people out here are at the cusp of a major change in the delivery of health care. And I'm not talking about the politics of it or, insurance versus not. That's all, we'll let other people deal with that. But the reality is that these are the people that are affected, and what we need to do, you need to do, particularly as healthcare professionals, is to advocate for prevention and wellness.
I definitely agree. And as a cancer surgeon, sometimes my patients ask me, well, what is it that they can do to help to prevent cancer? And the two things that I harp on is smoking is number one. And it's smoking has direct correlations to the development of lung cancer. However, smoking actually does affect most cancers, and it really can change your propensity to develop a cancer if you stop smoking. I always tell them that I'm not a moral person. I'm not telling them that because of morals. I'm telling them that because it really can affect their health. And then the second thing is actually getting exercise and being active. I think that those two things are the most important things to prevent and to encourage healthy living. And so it definitely is important, preventative medicine.
Well, one of our most preeminent cardiologists in all of Florida was sitting again in one of these chairs and said, you know, I can do some wonderful things, but unless you are willing to not smoke, be very cautious relative to intake of certain substances like alcohol or whatever. He didn't say you could stop, but he said be cautious. But the most important thing is exercise and hydration. He added hydration. And he said, I said, that's it? And he said, that is it. When I tell you, if I can get everybody who's listening to me now to do those things, I will see less patients and I will be happy. That's exactly what he said, right, sitting right here. So I feel that I'm getting the same emotions from both of you.
Absolutely. Things are changing. We hope that, you know, with these efforts, it's gonna take a long time, but the more we are involved in trying to prevent diseases, the less we're gonna need the healthcare system, the more productive and happier and more fulfilling life we're gonna live. And I think that that's our goal as you know, healthcare professionals. And I think that the public in general is you know, more getting the message and being more involved in that, and I think that's you know,
That's
nice
good
thing
for
to
all
see.
of us,
Yeah,
right?
absolutely.
Right. Well, we're down to the last 15 seconds of the show, so I'm going to say thank you, Dr. Ariel Rodriguez. Thank you very, very much. Where do you practice, by the way?
Delray Medical Center.
Delray Medical Center. All right. And Alia, Abdulla, where do you practice?
I practice through North Shore Medical Center.
North Shore, right, which is, well, it's affiliated with Palmetto General.
Yes, it is.
So thank you both very, very much. Thank you for your dedication. Thank you for your feeling for these viewers, because they see it through the camera. They know who's on their side, and you both have presented good feelings to these viewers. Folks, I hope you feel the same way that I do, and I also hope that if you have any questions or you want any answers, there's an email address right here. Remember, I always say take good care of yourself. This show is your show. It's called Dateline Health. We come to you from Nova Southeastern University, and my name is Fred Lippman. See you.